Okay, let's see. We've got one, two, three, four, five, six. All right, I'm going to turn it over to you, Jen.
Good morning. Happy Monday. It looks like we do have a quorum, correct? 1, 2,
I counted
3, 4,
six.
5, 6. Me too. Okay. Um, so I guess we'll officially start the meeting. Everybody want to look at the agenda and see if you have any questions or anything to add? Looks pretty light, actually.
It is very late.
Not hearing anything. Do we want to read December's minutes? Everybody would take a look and see if you have any adjustments.
I will scroll very slowly, so if anybody thinks I'm going too fast, please just tell me to stop.
I'd like to mention again that it would be really nice to have those ahead of time. Getting them this morning so that they can't be reviewed is a little difficult.
For whoever does it, this is Ruben. My correct spelling of my name is on the Zoom here.
Oh, I missed it again. We'll fix that.
I don't so much care, but I figure since it's a official document.
Absolutely.
I updated it for January's. Thank you.
I had forgotten we asked Ryan to join us. Is he going to be able to attend today?
That I do not know.
I will check with him.
Thanks, Tom.
Thank you.
We did get, looking at these notes around the annual data report, we did get that submitted to the General Assembly. And I have a finalized copy that I can share with this group.
Uh, when it's appropriate today in the meeting, it just reminded me looking at this. We had the whole conversation about. Sorry, this is Ruben. We had the whole conversation about gravely disabled and M1s and all that.
Mm-hmm.
And I actually had a really interesting meeting here the other day that shed a lot of new light on why some of that is done the way it's done. So I'd like to just talk about it a little more when we get there.
So let's go ahead and get that on the agenda. For anybody interested, all of the ASAM fourth revision documents are on the laws and rules website for BHA. All of the calendar updates are included. So if anybody wants to attend virtually in person, that kicked off last week. And so far, so good.
This Ruben, I would make a motion to accept the minutes as they are with the one correction I had.
I will go ahead and second that.
Okay. Minutes approved.
Sweet.
Moving on. 2765 review and updates.
turn it over to Tom.
Yeah.
Y'all didn't want me to cover changes we were going to make for 2765, right? In like it, particularly in terms of ECIC, just my announcement. Is that correct, Jessica?
Well, if you have ECIC updates that I'm not aware of, I would love to hear them.
Well, I just wondered if that was part of the context and certainly something that we're talking about here. But no, what I was planning on talking about was letting this important group of folks know that I've submitted my resignation here at BHA. In fact, this Friday is my last day, so that's coming right up. Um, in terms of the impact for this particular group, I don't actually think there's going to be much, if any, seeing that you're already in the very capable hands of Jessica Bell. In terms of my um, interim replacement at BHA, you'll also be pleased to know that Amy Hickson will serve as the interim division director of the Quality and Standards Group. She's been around for quite some time as the director of the licensing and designation. So essentially, what that means is she's been running the day-to-day activity of quality and standards for quite some time and has served as the interim division director in the past, and that went quite smoothly. So I don't think that that will cause any disruption. I have taken a position with the Department of Human Services as the Office Director of Children, Aging, and Community Services. So I begin that job officially on Monday, though I think Monday may be a holiday. So I suppose Tuesday of the following week. So, and would just say very quickly, it has been an honor and a pleasure to serve at BHA. I think this organization has undergone a tremendous revolution and for what it's done for behavioral health, bringing on, in particular, safety net services and transforming some of those services, and most recently, a new facility type of eating disorder treatment and recovery. There's much to do, but I think tremendous work has also been accomplished, and I'm pleased that I've been able to play a small role in that. So I wanted to let this group know of my departure, and again, that you're in good hands with Jessica and Amy, and happy to answer any questions that you may have about any of that.
Tom, I have loved working with you and I'm so sad, but at the same time, I'm so happy you're sticking around in just a different capacity. So I'm happy to be able to see you on that side of things.
Yes, absolutely, and thank you for saying that. I think it's probably obvious this is really just a shift in responsibilities and a small change in terms of administration to CDHS, and a lot of these things overlap anyway. So,
Yeah,
yeah,
absolutely.
thank you for that. Happy to answer any other questions.
Yeah, I will also miss you, Tom. The person that's in the interim position, is she a lawyer?
No, Amy Hickson is not. I would actually describe her as a clinician.
Okay.
She, just like Jessica, in fact, moved over from child welfare at CDHS, so has a history of that type of regulatory oversight,
Okay.
and certainly steeped in licensing, but not an attorney. And by the way, I don't think that's a prerequisite for the job. And I went to law school and did that work so many years ago. I can't remember any of it anyway.
Well, that's actually informative for me, because I suppose you can be that expert in this stuff and not be an attorney, but I didn't know. So thanks.
Yeah, it's when I applied for this particular job, that wasn't a prerequisite. I do think that there are overlaps, just generally speaking, when it comes to statutory analysis and regulatory construction, but I don't think that it's necessary to succeed in this job. And I think Amy's going to do fantastic work. In terms of organizational arrangements, I don't believe that Commissioner Smith has any, at least short-term, changes planned for quality and standards and where it fits within the organization. Of course, there's a lot that's going to happen in state government in the next year with the administration change, and that's just part of what happens in state government when there's a new governor. And we don't know yet, but it likely means changes in terms of executive leadership. I'm not talking about BHA in particular. I'm just talking generally. So we're probably likely to experience more changes in state government as a result of that than certainly within this organization. So hopefully that adds some context. And we certainly don't need to belabor this part of the conversation. I just wanted to make a quick announcement. So probably back to regularly scheduled programming.
I'll be inviting Amy to these moving forward. Not sure entirely what that will look like, but she is obviously more than welcome to attend. Tom, you had ECIC related updates? Because I don't have them.
No, I just wondered by the way the topic was introduced that maybe that's what y'all were hoping to talk about. And no, I don't think that conversation is quite ready for prime time. I would hint that maybe there's going to be some changes legislatively coming down the road with that, but we're in the very early parts of those conversations. So when that is ready for wider discussion, I think it will be important for this group to contemplate what that means, particularly in the context of that these two issues may be coming together in terms of the way the legislation is drafted. That'll be my foreshadowing hint, and then I'll exit quietly, stage left.
Way to leave on a cliffhanger.
That's the way you should do it, right?
Right? Keep them wanting more. All right. Did anybody have any questions, comments, concerns, 2765 related, Tom related, BHA related?
Quiet group today.
Yeah. Ruben, do you want to kick us off with this gravely disabled discussion?
Sure. So we had a meeting. Our my mobile integrated healthcare team does medical clearances for people that are needing to go to crisis unit, detox, et cetera. And we had a meeting with our medical director, who is a emergency medicine physician in Montrose, and Access Health Systems. And one of the things we found out was, Access expressed frustration that the ED doesn't use ECs, the emergency commitments, and that they do everything on an M1. And they're like, a lot of these would be better as an EC. What I found out was that apparently in the ER, an EC doesn't carry any legal weight. So in the ER, if the patient's on an emergency commitment, the ER can't stop them from leaving. If they're on an M1, they can actually detain them and hold them on that M1. But apparently the EC, as I understood it, I know many of you may have a broader knowledge of this and have something to contribute, but as I understood it, the EC only holds weight in a behavioral health facility in terms of holding someone. So anyway, it was news to me. It may not be news to any of you, but I thought it might be germane to that conversation we had had. So that's all the new things I learned. That's it.
Thank you.
Wondering, okay, someone did hear me.
We did hear you. Yes, thank you. Any additional comments, questions?
Yeah, I mean, I don't know if anyone from BHA proper can speak to this, but my experience is that there's a wide range of like how local hospitals treat these ECs and how they happen in practice. And I've seen, and the EC is a little tricky because anyone can write it, but you need a facility to accept it. And so I've sort of seen them treated. Again, it's a really local, there's a lot of local variation, but while it's pending EC, I've seen people say it's okay to enforce that EC, including restraints or coercive measures. But honestly, I don't know that I've ever heard from BHA, explicit guardrails for how to manage those. But I could just be out of, I, that doesn't mean that BHA hasn't done it. I just don't know myself. So.
Okay.
So I'm not quite understanding the issue here. So there's so an M1 hold is a hold for transport, or that's an M5, correct? An M5 is transport, and M1 is to hold. So can an M1 and an EC be instituted at the same time? Is actually I'm just wondering. I'm not sure legally how that works. And I'm wondering also, I know reading through the minutes, one of the things that is an issue is that more people are being held on M1s and then committed under a gravely disabled. And I'm kind of wondering if that's kind of one of the overlapping issues here, which I know, and I don't know if Tom, if you were talking about the psychiatric deterioration that's being added, is that the legislation you were referring to
It
the gravely
wasn't.
disabled? So there's a new there is a proposal to add some information about psychiatric deterioration to define that term within gravely disabled so that it's more likely that people would be committed both on M1s and NECs. So I'm not quite sure why there's both can't be instituted. So perhaps someone could clarify that.
Yeah, I think what you're identifying is that it, as a result of, and if we go back and look at this historically, thinking about um, substance use and mental health being separate systems and separate regulatory oversight, and really separate issues for people. And over the years, recognizing that these things are very frequently, if not always, comorbid, and that our systems need to be changed to treat the whole person. ASAM fourth edition being a primary example of how we want to braid funding in a different way, how we want providers to operate differently, and how we're removing certain kinds of treatment levels to bring all these things together. And from the 30,000 foot perspective, that emergency commitments and voluntary commitments and 72-hour mental health holds probably need to come together at some level also. So that, again, that's the 30,000 foot. Now, even organizationally, we treat these things differently. So emergency commitments are part of the adult continuum division under Mark Candigiani. And of course, 2765 has been part of the quality and standards division. And I think we need to think about that differently too. And so some of the legislation that you're talking about seeks to change some of the gravely disabled criteria. We'll see how that turns out. It's probably good. It's also a little bit scary when you open up those statutes. And then generally speaking, that maybe we should be thinking about differently about emergency commitments also. In terms of the specific data, I don't have that at my fingertips. Again, perhaps I'm less informed than I should be, but again, that's in a different division here in the organization. So that's as much specific as I can lend to that particular conversation. And by the way, I'm chatting with Ryan and asking him to come talk about some, if any, legislative changes. So maybe he'll have some more specifics about that, but had completely forgotten that part of why we wanted to have him come to see if he has any like form and manner about a member that has been named but hasn't come, and if we should, if he has any specifics about how this board would handle such a specific, if that's what the board would like him to discuss. Is that helpful? Okay. I asked him to come in 5 minutes, by the way, if that works for the board.
Perfect. Thank you.
Tom, do you know if any of these potential bills are on the legislative website yet?
That's the kind of trouble I get myself into by talking about things that maybe I shouldn't quite yet. So I don't know if they are up for general public yet. I don't think so. Samantha, were you going to weigh in on that?
I don't think anything is available to the general public yet.
Okay.
So I also had one more question, concern about, so I hear over and over about how that severe mental illness, or SPMI, and SUDs, so substance use disorders, are co-occurring. And not going to debate that one because that one's definitely true. The question I have is that when the treatment is put together as one big thing, it seems that substance use, and perhaps this has to do with who had the most advocates, but substance use tends to get priority in terms of residential facilities, in terms of placements, over people with specifically severe mental illness, psychotic spectrum disorders. So, and I saw this with my own daughter. I've seen this over and over and over with some of the advocacy groups I work with. And it's, it's a problem because I understand they're both a problem, and I understand they both come together, that there's a lot of co-occurrence, but it seems like as a behavioral health, like administration, the emphasis should be on the mental health, especially the severe mental illness, but the mental illness first, and the substance use, which is a symptom of mental illness, second. And it seems to be the other way around. This specifically occurs in some of the non-voluntary commitments or the voluntary commitments requiring that people are willing to change. If someone has severe mental illness and has anosognosia, they cannot be willing to change because they don't know they're ill. And I just that's just a conflation that I'm constantly kind of wondering about and concerned about.
I think that's an excellent point. I wonder whether some of our providers and clinicians may speak to why that is the case. My initial thought would be, I think so much of it has to do with cost, that our mental health facilities are traditionally the most expensive to own and operate. But I think benefiting from the expertise of the people in this group that have done that kind of work could be really helpful. I don't want to put any specifics on the spot. No, Samantha, I see your hand up.
I just have a question that I'm reminded of based on this, related to voluntary and involuntary treatment and SMI. And Tom, as long as you're the guy, it's a BHA regulations question. So I'm just curious. The no eject, no reject clauses for safety net providers, are those tied to the client requesting the services? And if so, how are people with SMI who may need involuntary treatment ever going to get treatment if then they can't be in that category of clients who can't be rejected?
If I understand your question correctly, and you stop me if I start to mess this up, Samantha, is to what facilities does the no refusal requirement apply? And then maybe I'm reading too much in it, because I get this concern expressed in other settings, and that is, hey, look, if this system's really going to work, you need a broader authority, BHA, to have the no refusal requirements apply to other facilities beyond just a comprehensive safety net provider. That we have 19 of those in the state, and you're only telling those organizations they can't say no. What about all the other places where people get services? Did
I mean, that's an important
I
conversation too, but I'm actually talking about the facilities where, or the agencies where the no refusal requirement already applies.
Mm-hmm.
We've been hearing sometimes that the no refusal requirement only applies if the client is seeking services, which means if we have clients who are not able to voluntarily seek services, they are being refused, and the no refusal requirement, from what we've been told per BHA regulations, doesn't apply because the client themselves is not the one seeking services. Does that make sense?
I'm not sure I get it. Like, hey, if a person may be too ill to actively seek services, or if a family member or guardian is seeking services on their behalf, is that the scenario?
Or theoretically, if an inpatient facility is seeking services for someone to step down, but that is not the client seeking services, then the client can still be refused, even if the client is not in a position to request services, but is also no longer needing inpatient level care.
Tom, I can try to take this one if
Yeah.
you want me to.
Yeah.
And Kelly, I think I can try to take yours as well. So I'm Karen Rice. I'm the executive vice president at Clinica, which is one of these 19 that Tom is talking about. So we're under that no reject, no eject. I think, if a patient is that ill, like those are patients that we would look to put on certification. So they would be that forced treatment. And I think then you get into all the issues we've had with, like Tom was saying earlier, you can't really just force treatment in a vacuum. You need all the community players to be on board, whether that be the law enforcement, the courts, whatever. So I think that there is a component to a patient has to want to receive services, but there are limits where we feel like the patient is not in their right mind to refuse the services or not want, and that's exactly when you would initiate a certification. So I don't know if that answers your question, Samantha.
I mean, it does align with what I think is like these are likely clients who would need to be on a cert.
Yeah.
But from my understanding is that the problem is arising with the fact that because the client is not seeking services, the no reject clause doesn't apply.
Well, I mean, if you're gonna there has to be some amount of buy-in, because you can't just force someone to get services if they're not, if they don't lack capacity to make their own medical decisions. So there is a limit as how far you can push that.
The issue of refusing certifications, I think that's the vernacular we've used in the system, is longstanding, and I would argue that a facility subject to no refusal requirements in the regulations is also subject to those same requirements for a person that's been placed on a certification, as Dr. Rice just talked about in terms of like a clinical decision and process. The I think the nuance here is if a person is not on a certification and the facility in question would say, hey, look, we think that they need to be served by this organization, a safety net provider, but the person in question who's not on the certification says, I don't want services. And if their rights haven't been removed by a court, then their determination is going to stand. And that organization wouldn't be obligated to serve if the person says, nope, I'm not going to go. Hence why the certification process may be necessary. But that's tough when you cross the bright line into meeting the criteria for short or long-term certification. And I think then we get into that very difficult space that has been at issue in the system for quite some time, even before we invented what a safety net is and no refusal requirements. I hope that that's an okay place to maybe leave that conversation temporarily. I did ask Ryan to come. And so, Ryan, I think what the team was after was any legislative updates that you'd care to share that you think might be relevant for this particular group. And then also technical assistance for a member that was appointed to the committee, but has never come to any meetings, and any advice that you could give the group, maybe bylaws or statutory in terms of like boards and commissions, for when you can remove a person or what duty a board would have for further notice or due process or anything like that.
All right, thanks, Tom. I'm Ryan Templeton, Legislative Director with the Behavioral Health Administration. So that, let me get this right, there is a member appointed that has yet to show up. Is that the case? Okay, I will reach out to Gov's office boards and commissions and kind of talk through that appointment process to make sure that they're on board with the
Hey,
kind of
Ryan.
next steps. Yeah.
We also just wanted to follow up with you because there were several people that are new board members that have never received their certificate from the Gov's office or any other like official appointment announcement. And so we're wondering if that might be part of it, of why they've never shown up. Just letting you know that that's also in the mix.
Good to know. Thanks, Jess. Yeah, so I'll follow up with Gov's office. I know there was the executive order that did go out, so it maybe just didn't get to the right spot. So I'll double check all that stuff. Legislative update quickly here, right? The session starts on Wednesday, goes for 120 consecutive days. So roughly May 13th is the last day, a week later than normal. Start here. BHA has 3 legislative agenda items, so that we are championing recovery residence oversight. Right now, if folks know about how recovery residents operate, we as BHA approve a certifying body. So part of this legislation would be moving that certification in-house instead of to that third party, which allows us to better align with what our licensing of health facilities, behavioral health facility oversight looks like currently. That one, it looks like it's going to be Representative McCormick running that piece for us. The other one, Safeguard 988 revenue. You'll see this that has impact across a couple different revenue streams, both 988 our crisis hotline, 911, and the communication services for people with disabilities. The Department of Revenue issued a notice about redefining what an outdated term for wireless communication service means. So that impacted communication providers and their ability or their requirement to have to pay the fees that support 988, 911 and that communications with people with disabilities. It's a net neutral, so a no funding impact, but it would potentially have a few $1 million annual funding impact if communication service providers were to fall in line with that Department of Revenue. So it's an update to a definition of a prepaid wireless communication service, which you'll see that one as a 988 and 911 impact there. Last one, behavioral health entity building inspections. Part of that is we want to make updates to inspection requirements for outpatient and telehealth behavioral health providers, that they don't have to get the FPC, Division of Facility or Fire Protection Control certificate of compliance. If you're a telehealth only behavioral health entity, you don't have to get a certificate of compliance because you provide telehealth services, and that for outpatient only providers is that you can use your local um, fire agency to do that if as long as that fire agency is approved by DFPC. Really trying to help with that administrative burden of getting licensed, especially for those telehealth and outpatient providers. So those are our three. We are also tracking a whole bunch of other pieces of legislation impacting behavioral health, from um, emergency commitment for SUD pieces, some definitional changes to 2765, some stuff related to the competency and how that intersects with um, incompetent to proceed to short-term certification and pieces like that, as well as PhD, CJJS, the secure transportation, as well as MAT in jails from that um, interim committee, which I see Kevin on, which he's here quite a bit too. With that, a quick update on budget requests. It's a reduction year again. We're at about a $850 million deficit is the last figure that I had seen. So all state agencies had to submit reductions for their state budgets. We went through our JVC hearing before the holidays. With that, our total reduction for BHA is about $5.9 million reduction over five specific budget requests, including administrative reductions, so FTE at BHA, as well as repealing technical assistance programs, as well as some programs that have less of a direct service delivery impact and more of outgoing expansion services. We know that expanding services when there's not ongoing funding associated with that is tough on providers as well as the system, as well as right sizing some of our programs based on previous reductions. One big one that we've been receiving a lot of feedback on is that there's a recycled reduction. What that means is last year, 2025 session, when JVC took action on a bill based on, or action on a program based on streamlining budget or getting a budget to align with revenue. The Recovery Support Services grant was a reduction. Stakeholders, community came forward, and that did not move forward, but that was considered a recycle reduction for this year, as JVC made action last year, but it didn't go through during the 2025 session. So that's a $1.6 million reduction to one of our Recovery Support Services grants, which equals out to our $5.9 million reduction. We really try to focus a lot on the as least amount of impact to direct service delivery as possible with reductions. This, right, again, is going to be a tough budget year, and there's already talk about the following year is going to be even worse. So be on the lookout for that as kind of a big driver of the legislative session is our funding challenges as the state. That was quick and dirty. Questions?
Thank you, Ryan.
Yep, Jess, I'll work back with you through Gov's office boards and commissions on making sure that new folks both get their appointment letters as well as follow through with how we can support active engagement.
Thank you.
Thanks, Ryan.
Any other questions for Ryan? Okay.
I'm going to go back. If we're ready to move on, that is, I'm going to go ahead and share my screen again, and we'll start going back to those questions for the inpatient facilities. Does anybody have anything else they want to talk about before we make that transition?
I can reply while you're doing that. I can kind of respond to Kelly's earlier comment about the SUD and mental health issues being treated concurrently. So I think, ideally, you don't treat one first, you treat them both at the same time. And I think some of the new regulations that are coming out from changes to ASAM will make all SUD treatment facilities really more medical. But that then goes back to what Tom was saying about cost. When you make something more medical, it costs more money, obviously. And I think one of the issues with the current SUD treatment is a lot of those facilities don't require a lot. There's some medical requirement, but it's minimal to the point where it would be hard to be treating, especially SPMI patients in those facilities. So I think ultimately the answer to this is you need to have more psychiatric medical care combined with the SUD so that you can address both. And that is very much the intention of ASAM 4th edition and the changes that we'll be making in July of 27.
Thank you, Karen. I do think, though, there's still this problem with the emphasis on a willingness to change. And I understand you can't give therapy if someone's not willing to engage, but you can give antipsychotics. So and in order to get someone to a point where they might be willing to change, they've got to come out of psychosis. So that's kind of the problem where I'm seeing that overlap with substance use and psychiatric getting conflated like that. That's really one of the biggest issues.
Yeah, it's definitely a hard position, especially for loved ones and family members to be in. I think where it's hard on the other side is just, at what point can you take someone's rights away? And it's probably one of the hardest things that as a psychiatrist I have to deal with. So it's not easy for anybody, but there's such a kind of slippery slope with trying to get someone the help they absolutely need without without the absolute need of taking rights away is challenging.
Are we ready to transition? Okay. Can everybody see what's on screen right now? So this is kind of where we left off. I'm probably thinking that just given how things, like the cadence of these meetings, we're probably going to be shooting for like a March time to try and get some people from our inpatient or psych hospitals to join us. I don't think we've fully identified who our target audience is. If we were wanting to invite admin, if we were wanting to invite clinical, like who are we trying to engage in this conversation from these facilities? And as a reminder, this is a list of questions that we would be providing to whoever that contact is so that they have some kind of context of what we wanted to discuss and not be blindsided or feel like we're coming in and making accusations or attacking.
That's good. I think it's hard to define the target audience in context. I know I work with probably all the inpatient hospitals across the state, and it seems like each or almost each facility has a different person that manages the 2765 piece. So it may be that, the psychiatrists are very well versed in 2765, but they're not the ones sending out the information or passing on legal information. And so then me personally, I find that I'm trying to reach out to people that I'm communicating with, which may be a social worker who has no idea what I'm talking about. And I think it's just hard to know which facility, who handles the majority of the legal paperwork or legal processes at each facility, because it's different.
Yeah, I'm sure that there are multiple, like, answering all of these is going to kind of require a team effort on the other side. And I apologize, I missed the first couple minutes of the meeting, so maybe I just want to make sure. So is the goal of this is for our group here to sort of understand the current state, or are we trying to resolve things for the inpatient? Sorry, Jess, I just want to make sure I understand kind of what the role of these questions is. Yeah.
It really is to provide a better understanding to this group, like how we're currently operating. I think having that base knowledge will give us better insight in how to make recommendations moving forward.
Okay.
Because some of these are pretty frequently asked. I'm actually working on like a frequently asked questions document for family members, and like some of these around like, how are you contacting me? Like the facility is refusing to release information about my loved one. Like I know they're there and they won't even tell me that. So there's like things like that that are going to be kind of overlapping. But yeah, if we can, I think it's going to go both ways. I think we're going to be able to educate during that meeting, and I think we're going to learn a lot during that meeting if we can make it happen.
Yeah. And at the risk of, if I can throw something out, we can parking lot it. We don't have to go down this rabbit hole. But I would say that, like, I just want to make, depending on what we're doing with it, there might be like real methods questions, like what is our response rate? Is this going to be required by you all of a response? So I just want to make sure that we're getting good information and we know how to interpret that. One idea I'll just throw out is, I wonder if, facilities might be interested in a little bit of an FAQ, or can there be a publicly posted chat where BHA opines on these common questions, or maybe things that you all see in surveys? The Joint Commission does kind of alerts and FYIs generally. And so I raise that not only because it might be helpful for everyone, but it might also motivate people to respond and participate. Like, hey, these are things I'd like to know about. And like to fix before we get, visited by BHA.
And we did. And so part of our troubles we're having with this vacancy in the boards and commissions role is they started a form where public could submit 2765 related questions. I don't know of anybody besides that person who had access to that document. So I don't even know where to begin, because I've requested access and I've still not gotten it.
I think one more thing you could add to this list under the how are you contacting loved ones and families is I've run into quite a few facilities that are not even aware that the Friends and Family form exists. I know it's open on the BHA website. I know that Denver Health, for example, I'm on their advisory board, and they specifically said they were like, what? This thing exists? So just saying, this is something that maybe needs to be communicated better.
I'll just weigh in very quickly on the Friends and Family form. We are going to update our rules to say that one, it exists, and two, that it is required that facilities fill it out. So maybe better late than never, but it is something that we should have updated our regulations to reflect sooner than now. So my apologies.
Looks like Scott's asking about cell phones. That is often a question among units, although now that the requirement is out there, it seems like people have figured it out.
Yeah, I was gonna say, I, at this point now, have seen very few cell phone violations. People are implementing it, they're using it. I do get some questions of like, is this an appropriate restriction when X, Y, and Z happens? But for the most part, it has been implemented. We're still not seeing, knock on wood, any critical incident reports for breach of confidentiality because of cell phones from clients, is what I will say. We still see it from staff, but we don't see it from clients.
That's good.
Yeah. What are some other questions or things that have come up that you would want to be able to have discussions around? I know we talked, where is it? Number 5. We really talked about like some exclusionary criteria. And we had briefly touched on it earlier today around this no refusal requirement, but most of our psych hospitals are not safety net. I can't think of any that actually is safety net, to be quite honest.
Well, one question on the exclusion criteria might be, do you have written exclusion criteria and can share? Because that would be sort of a way to compare. And one of the challenges with this is it often feels like a moving target for those of us who are referring to these programs. So,
they are required under our regulations to have them. So I know like when we get a specific complaint, we will look into it.
Oh, I didn't realize that. Okay.
Yeah.
I want to make sure I understood you correctly. There are no psych hospitals that fall under safety net?
Correct. They are independently practicing private entities.
That is a huge problem.
That's what I was alluding to earlier when I said that the no refusal requirements pertain to comprehensive safety net providers, but no other organizations in the behavioral health system. And I would, if I can put words in CBHC's mouth, because I think that it's an excellent point. And they've said several times in several different forums, hey, it's not that we disagree with no refusal requirements. It's that we think that it's too limited in scope. Why just this organizational type is subject to that? And then I think that it's been a fairly regular topic of conversation in this group. While BHA designates psychiatric hospitals, BHA does not license psychiatric hospitals. So it's a narrower type of authority. And when it comes to emergency departments, I think that people probably have lots of different views about the role of emergency departments in the behavioral health continuum. BHA has neither licensing nor designation authority over emergency departments. So even more broadly than no refusal, I think it's important to remind ourselves that behavioral health authority is dispersed amongst a wide variety of organizations throughout Colorado, plus some federal authorities as well. That certainly makes these conversations more difficult, and solutions, I would suggest, more difficult as well.
So is BHA connected with the state hospitals? I know that falls under the Office of Civil and Forensic Mental Health, but is there a connection? Because those are regulated by the state, as far as I know. So I'm just, so like Fort Logan or Pueblo.
Yeah. Like any other hospital licensed by CDPHE as a psychiatric hospital and designated by BHA for the 2765 component of their work.
The easiest way to kind of recognize it for everyone on this call, if they lost their 2765 designation from BHA, they would still be a hospital. They just would not be allowed to do involuntary services.
That's a perfect way to explain the difference between a license and what a license does. It's like a business license to actually operate, and then the narrower scope of 2765. Thanks, Jess.
What other things are people interested in having a conversation around some of this inpatient 2765? Are there specific locations you would like us to prioritize when we're reaching out? And we already have Jen here from Fort Logan.
Can you scroll up again? Okay, I would, one of the biggest challenges we have, especially even around 2765, is kind of the transitions of care to the outpatient and some of the stuff around, even with certifications, they're supposed to communicate that 72 hours in advance. Like, that's not happening.
Right.
I don't know if they would admit to it not happening, but also I'd be curious what their experience is with certifications in terms of finding outside provider or outpatient providers to take them. Even things like sending discharge notes. Some hospitals say that their restrictions on sharing information are more strict, so they won't even send them. And if the patient is gone, good luck ever trying to get those records, even if they're coming to your office. So just a little bit more about how they do their transitions of care.
We do have that down here.
Oh, you do? Okay.
Oh, I think it's important that we start talking about the outpatient certification also. We're having some internal discussions around, excuse me, some of our current safety net providers who are not offering. I mean, they are offering, but they're not providing 2765 outpatient certification care.
Right. And we've got into why.
Yeah.
Yeah. So I guess that's what I was trying to make sure I didn't miss, but I'm just trying to see if this words it in a way that, what's the process for other facilities to obtain medical records? I don't know. It's very similar, but what is the process? How do you ensure that your hospital stay information is adequately given to the outpatient provider? So more like it's on them to do something. So what did they actually do actively, and not just have the burden fall on the outpatient provider to do everything, like get the records and such? Because that's often what happens too. If you get the records, it has to be initiated by the outpatient provider, which is super challenging. Could they be doing more just as someone before they walk out the door to make sure that transition goes smoothly? So I just wanted that perspective in there.
And that is something that we built out further in the Chapter 11 revisions for ASAM 4, because that was an area that we recognized, like, there's not a lot of detail here, and people are falling through the cracks. So that was expanded a little bit, also along with the outpatient certification expectations.
Thanks.
Yeah.
I read some of those this weekend between football games, but I didn't get to Chapter 11.
Oh my goodness, don't spend your weekends reading.
Regulations. Time. That was TMI for most of you. What does Karen do on her weekend? I had a good weekend though. So.
I mean, if that's how you enjoy your free time.
No, it's not.
Cheers to that, time. Dr. Rice.
One other idea for this list I want to throw out there. I don't know if we get good information, but the other thing that comes up is there are facilities that will not accept patients voluntarily because they request a mental health hold before admitting this patient. And so I doubt that anyone has written rules, but it would sort of be interesting. Like, do you have expectations or a mental health hold? Do you request a mental health hold before admitting someone? And I think ancillary to that is I think a lot of facilities do that because it can be hard to, they want to avoid having to write after hours mental health holds for patients who want to leave. So I do wonder is like, what are your arrangements for patients who need involuntary treatment orders after hours? I don't know. It's kind of an incomplete thought. This is just something I experience anecdotally that I think is a barrier to care, and maybe it's not the right venue to go after it, but I just wanted to throw it out there and see.
No, thank you for bringing that up. I have heard that recently where I've gotten a couple of different complaints where they were like, you absolutely have to place a hold before we'll accept them. That's like a contingency of us accepting them to treatment. And I was like, that's violating the law, but okay.
Well, I will say, Jess, that I have submitted complaints to BHA about that. And when surveyed, BHA came back and said that facilities are allowed to do that. That was a couple years ago, but there's not always been a consistent message in that space.
Well, let's fix that. I love making waves, as Tom well knows.
That actually is a issue that's near and dear to my heart. I can remember back to regulations, maybe going back 5 to 7 years, and believe that it has always been clear, both in statute and in rule, that facilities are required to treat people voluntarily, and that unless they meet that criteria, aren't to put people on involuntary care status. And having experienced that exact same thing for a family member when I was trying to be a dad and not a BHA employee, took great umbrage with that particular facility's handling of that case. So if we get such a complaint, we will vigorously investigate that. And I have always appreciated Jessica's approach to handling those kinds of things. So kudos, Jessica.
What can I say? I like civil rights.
Yeah, that's a big reason that those statutes and regulations exist. And if I can put words in my fellow state employees' mouths, that's why we do the work that we do. That's why we're here.
Anything else for this list? We've got a little more than 20 minutes left.
I'm not seeing it on there, but maybe it is on this list and I'm just not finding it because the list keeps going up and down like this. But I'm wondering if there's anything about what the criteria are for releasing someone from a hold. I ask because we experienced on multiple occasions that the reason they were actually releasing them from a hold was that the insurance wasn't paying. So I would be interested in finding out what their actual criteria is.
And we can absolutely discuss that because there are provisions now in the law that says you cannot release them if they still meet criteria. And that is something
testified on that bill.
What else?
So that one also, I mean, even when when it's not an insurance issue, that is a removal of someone's civil rights to keep them on an involuntary hold. And I'm wondering how those decisions, like I would really like to know a little more in depth about how that decision is made, about when someone is released. How do you define danger to self or others in that, like the hospitals themselves? I know how it's defined in the statute, but how that's defined by the hospitals, how that's defined in terms of gravely disabled, how do they I would like more information about their criteria on that from the facilities themselves because it varies pretty widely.
For sure. And I think the problem we're going to come up across is because BHA doesn't have regulatory oversight in any capacity with the emergency departments, we're going to miss a huge piece of that conversation. What else?
Not exactly sure how to question this, but I know there's a significant difference between facilities such as Denver Health that has access to more complex medical care versus like Highlands that doesn't have that medical component. Um, so maybe something along the lines of used to be called IMD. I don't think IMDs exist anymore, right?
No, that's still a thing. It's a
It
federal.
is still a thing.
That's a federal rule. Yeah, they don't update those.
So something along those lines. I'm just not sure how to ask it. Like, what are your medical capabilities and
Limitations.
limitations? There you go. Yeah.
Scott, say more about this OT question.
Oh, I just really like the discharge readiness question, and so there are a lot of occupational therapy preparedness to live on your like evaluations that could be used, or there's standardized assessments that people use to determine whether people can self-care, for example. Yeah, that's why I was just sort of thinking about how to standardize like some questions around discharge preparedness. So
Gotcha. I think that one's going to get complicated because we have a lot, like just judging by the data, we have a lot of people that live with other people that assist in that caregiving. So that would not be the sole determinant for discharge, if that makes sense.
no, definitely not. But it's something that could. There are all right. There are all kinds of functional evaluations, like how much supervision does someone need? What do they need help with? What, you know, would they be
I think
safe
that
at
goes,
home?
so
But
Scott, I think that goes along with Dr. Rice's question as well, the communication between facilities. So if
yes,
you're looking at a hold and someone's been on, 3 different holds in the last, month, you might make a different determination than and so that communication piece that she was talking about is super important. Um, and having a history that goes beyond just that one facility.
What else?
I have one that kind of piggybacks on 11.
Okay.
Just more detail about, especially as we're trying to not utilize emergency rooms as much. Some hospitals still require, even if they go to a crisis center, to go to the ED for clearance before they'll admit them. So, specifically, do you require patients to go through the emergency room? I don't know if some of them like it would be really nice if those facilities had the ability to do a medical clearance, so then it wouldn't be like, always up to that external person. But do they do any medical clearance? Do they do direct admits from crisis centers? If yes, like what is required of the crisis center? Because we have hospitals telling us different things. Everyone has their own criteria.
What else?
This might be a little contentious, but what do they do when people are homeless? I think, in the regular hospital, working their way back in residency, it's like you can't discharge people to the street, but they very much do that. If someone can't they send them in a lift to the shelter maybe, or to their appointment. So then the outpatient provider, like directly to the outpatient appointment. So then the outpatient provider is like responsible for everything. So
Trying to figure out how else to add to this one.
what's that?
Oh, thinking out loud.
Okay.
Like, how do you handle clients that are unhoused? What does that discharge plan look like? And I feel like I'm missing a part of this.
I mean, well, I don't know if it's kind of related, but do you send people in lifts out of the hospital? I don't know if regular med surg hospitals can do that. It's too long since I've been in that. We didn't have ride shares when I went through that. For example, after a procedure, you can't just send someone home in a lift. They have to have someone pick them up. I don't know if that's how they discharge med surg patients. So again, just kind of getting at the parity. Why would we send someone in a lift when other hospitals can't? But maybe they can. I don't know. Okay, thank you, Scott. So I think Scott probably just answered the question. Yes.
Yeah, I do get complaints on this one. I have one right now where an individual is discharged to Stout Street Clinic and no one actually talked to the clinic.
Yeah, that sounds pretty common.
Oh, because they were like,
some of these hospitals are like, Colorado Springs will discharge a homeless patient to Boulder. Like some of them don't even pay for the lift to get them back to Boulder. And when we admit them, we have no choice at where they go. So that's another problem. It's like, how do you, if a patient doesn't have a family member or anyone to pick them up, is that their only solution? And do you even do that if they live far away with the lift?
As a family member, I would like to also mention that discharging people to a family member when the person's still a danger to self and others is also problematic, and it happens over and over. I've heard of people being attacked by their mentally ill children. I personally have been attacked by my mentally ill child. So that was after a release. They released her to me in full psychosis. So I'm kind of wondering, that, not just in terms of releasing homeless adults to shelters, but also releasing them back into the public when they are still a danger to themselves and others. Which I know isn't supposed to happen. I get that.
All right, we've got about 12 minutes left. what I would like to do is I would like to take this back to my 2765 team, do a little bit of revisions to kind of give us topics, keeping the questions as is, just organizing it a little bit better, and figuring out who we can invite to the March meeting. See who was willing to come and have those conversations. And maybe it's something we have to do over March and April or several months, however it needs to be, just so that we can have multiple hospitals available for this discussion. I think part of framing it is going to be of like, this is not a regulatory gotcha meeting. This is a, members of the larger community in the system have just concerns with how the system works and want to talk through what the current practices are so that we can understand better where we can make bigger impacts.
I wonder if it's also possible to have like names and titles. So, Susie Smith is the 2765 coordinator at Highlands, or Dr. Simpson writes all the certifications, like that kind of thing, before the meeting, just so we have a heads up and maybe could prepare our questions. Yeah.
Yeah, for sure.
I'm also happy to answer all of those questions for the state hospital.
Right. Trying to find our agenda. So we just have like public comment at this point. So if there's any member of the public that wanted to come off mute and ask questions, floor is yours.
No?
Cool.
Okay.
Should we adjourn a little early?
I think that would be lovely. I'm really glad we switched to an hour and a half instead of 2 hours. We also, maybe for the next meeting, do we want to discuss our next in-person option?
Put it on the agenda for February, is that what you're saying?
Yeah.
We can definitely do that. All right.
Okay.
Thank you, everyone, for your time this morning, and we will see you in February.
Bye.
Bye.